with no waxing and waning of symptoms. Initially, she considered it normal, but it was persisting even after he grew older.
Okay, Dr. Gopika, did you pause there? Or
No,
have
ma'am.
you lost connection? Go on then.
He had history of multiple falls while walking, no history of any major trauma due to falls, and he was not going for playing in school ground and not used to participate in running games. And he started schooling at 5 years, and he had a below average scholastic performance according to mother and teachers, and he had difficulties in memorizing poems and stories and difficulties in writing, and he could remember learned matter only for few hours. And now he can write his name but in form of bigger letters, and letters will be written in a scattered manner in a page. And he was able to eat food by himself, but there is history of spilling of water from fully filled glass when he tries to have it. Then mother noticed that he had tremor of fingers when trying to bring food and water to his mouth and while holding pen. There is no history of difficulty in climbing upstairs, and he was taken to a pediatrician at 6 years and was advised to start on speech therapy, and no detailed evaluation was done at that time. And speech therapy was taken only for 1 year, and then they stopped on their own as they did not notice any improvement. And due to persistence of symptoms, child was taken to another hospital at about 7 to 8 years, and he was advised for IQ testing, but it was not performed. And as time progressed, his symptoms remained the same, and mother did not notice any worsening of symptoms. And as he was not able to do simple maths calculations like addition, subtraction, and there was reduction in intellectual function as compared to peer children. And at 13 years, he had an OPD visit for fever and rhinitis and was advised by pediatrician to consult a pediatric neurologist for detailed evaluation. And he is able to lift his arm above head, but has difficulty in reaching or holding objects due to tremors. He has difficulties in writing. He is able to lift his head from bed and able to sit from supine position. He can turn from one side to other while lying on bed. He has mild difficulty to get up from sitting position. He is able to grip his chappals on foot. He is able to hear well and comprehend spoken words. Currently, he is able to dress his shirt with buttoning by himself with both right and left hand, but takes a long time to do so. He is able to perceive temperature of hot tea or cold water while bathing. He is able to perceive pain. He is able to feel his shirts while dressing. No history of difficulty in perception of smell. No history of abnormal eye movements or speed. No history of drooling of saliva, collection of food in cheek, deviation of angle of mouth while eating, and is able to chew food well. No history of hearing abnormality or tinnitus. No history of nasal regurgitation, swallowing difficulty, or recent voice change. There is no history of bowel or bladder disturbances. No history of persistent headache, vomiting, or double vision. No history of drowsiness, confusion, aggression, or psychosis. No history of dizziness or a spinning sensation. No history of dryness of skin. No history of any eye changes or vision abnormalities. No history of flushing of skin or excessive sweating. No history of salivary disturbances. No history of back pain or spinal deformity. No history of emotional lability or any sleep disturbance. And also no history of regression of attained milestones. So no history of vision problems, no history suggestive of muscle weakness, no history of constipation or passage of foul-smelling oily stools, no history of recurrent ear infections or ear discharge, no history of jaundice, failure to thrive or behavioral abnormality, no history of abdominal pain, photosensitivity or recent change in urine color. Coming to history of...
Just a minute, can you go to the first slide?
Okay.
The chief complaints are reduced clarity of speech noted from 3 years of age. And you have said a lot of history about the speech. And can you reiterate what you said about the speech? And what is your deduction from that? What sort of speech do you think the patient has?
He's able to communicate is what he meant,
No,
but
no, that
the
is you said you are talking about the not the speech. Actually, you said that he's able. His speech is normal. Just repeat what you said about the misarticulation that you're driving at. There's reduced
while
clarity, but though the content of speech is normal. That's
uh,
what you
content
said. Uh,
uh, content of speech is normal, but pronunciation is unclear.
the articulation is abnormal. What is the articulatory abnormality? You have said it somewhere. You did speak about it. What are the different problems that could produce misarticulation, such as a?
Articulation.
It is obvious that you're speaking about a child who is having unsteadiness, no? From your
Okay.
history. So, what sort
Uh,
of misarticulation will you expect in that child? Articulatory problem will you expect?
it can be due
You,
to some cerebellar problem.
so, what are those speech, different types of speech that you get in cerebellar abnormality?
Mm,
Have you heard about scanning speech and staccato
Stack,
speech?
yes, ma'am. Staccato speech or scanning speech.
What are what from your history? The patient is having unsteadiness. Patient is possibly having scanning speech. Somewhere you said that the syllables are separate, I think. But what is the
He
other
used to
type
be,
of? Hmm,
he used to
what is
leave
the?
some
Uh, hmm.
unintentional pauses between certain
Uh,
words.
Between the syllables, there were a lot of pauses, which makes it clear that this is a scanning speech. Now, what other sort of misarticulation would you like to rule out in the history? When the patient obviously has a cerebral abnormality, now what sort of other misarticulation do you want to? Do you want to rule out the spastic speech also?
Hmm.
So this child had unsteadiness while walking, noted from about 3.5 to 4 years. From your history, you're sure, have you made out that the child's gait was normal at 1 year of age? Are you sure that the gait was normal at 1 year?
Mother
That
started
the walk.
noticing only after between 3 to 4 years, she told. After,
Ah, did you ask them specifically whether there was some limping or something before this time?
no, ma'am.
We want to know the exact age of onset. That is why we should ask that. First
Okay.
scholastic performance was noticed after schooling began from 5 years of age. Okay, we'll take that. The next slide. By saying that poor scholastic performance is noticed after 5 years of age, we mean that the child was scholastically normal, that there was no mental subnormality before 5 years of age. So actually, we have to probe the history and find out exactly whether the child had some intellectual deficiency before 5 years of age. Now, if a child was normal until 5 years of age and then had and then started having a scholastic problem, what are the differential diagnoses in your mind? What could be the reason why the child is normal up to 5 years of age and then loses scholastic skills?
It can be due to some regression,
You,
neuroregressive disorders.
you did not hear. What did you say?
It can be due to some regression in the
What would be the disease that makes a child lose scholastic ability at 5 years of age? Is it GM1 gangliosidosis, GM2 gangliosidosis, metachromatic leukodystrophy, Grab disease, leukopolysaccharose? What are the diseases that could make a child lose his scholastic skills by 5 years of age. Suppose you're seeing him at 5 year, 2 months, and the mother says for the last 2 months the child is having scholastic backwardness.
Metachromatic leukodystrophy.
Metachromatic leukodystrophy usually has an onset around the end of the first year of life. That is why it is called late infantile metachromatic leukodystrophy. When the child is 5 years old.
Okay.
One of the commonest
disease can be
Wilson's disease, that is the commonest. That makes a child lose scholastic ability by 5 years of age. Then if it was a short duration illness, we'll always think about subacute sclerosis and thalassemia. But in this child, the duration is very long, and we have not brought out the history that could support SSPA. So the child was apparently normal till 3 years of age when the mother noticed reduced clarity of speech that we have already said. Then the speech, we do not call this pronunciation, it's articulation. The speech content and meaning was good, and the child was able to communicate the meaning, and pronunciation was unclear. That's what you write. You have written. He used to leave abnormal pauses. That is clearly stating that the child is having a scanning speech. And he started walking without support by 1.5 years. That means that walking was delayed. You have actually brought out the history. So the onset could have been at 1 year of age because child did not walk. Now again, we want to know whether other motor milestones were normal before 1 year of age.
Okay.
Because now you have brought out that the child did not walk at 1 year of age. And better than saying it in the past history is to bring it out now. And by about 3.5 to 4 years, the mother noticed a wide-based gait and unsteadiness while walking, which was insidious in onset, gradually progressive. What do you conclude from that statement?
He has a gradually progressive ataxia.
Ataxia. What else do we want to know at this point of time? Obviously, there's a gradually progressive ataxia, and it is not waxing or waning. It is not relapsing limiting. It's gradually progressive. What else do we want to know? It is a long track that is involved. The cerebellar system is involved. You would like to know whether the child is having pyramidal tract involvement, extrapyramidal involvement. At this point in time, we certainly want to know that. And how will you bring that out?
History of any abnormal movements we can ask.
Okay, any abnormal movement we'd like to know, then or posturing. Then whether the mother has noticed any stiffness of the limbs, whether she has noticed a rhythmic movement of the lower limb.
No, ma'am. No such history.
You have to say that. No?
Okay.
Before you are questioned about it. Someone has said that they would like to know whether the child had seizures. That is also true. We want to know what are the other parts of the nervous system that are affected. We immediately want to know whether there are seizures. But in addition to seizures, we should say that there is no sudden jerk-like movements, that there are no myoclonic jerks. So these diseases that present with chronically progressive ataxia, they have multifocal myoclonus associated, especially in Wilson's disease and in mitochondrial cytopathies presenting with chronic ataxia. You have multifocal myoclonus associated. So certainly we want to know whether the patient has seizures and whether there is a myoclonus-like movement seen at any time. And we would like to get the history of pyramidal tract involvement, extrapyramidal tract involvement. You have already spoken about the intellect of the child. So you think about all of the other parts of neuraxis, we want to find out in the history where there is involvement. So go on to next slide. Next slide. So here the history of multiple falls while walking, and what do you think that was due to?
It may be due to ataxia.
What could be the different reasons? One is ataxia could be the reason. Could it be due to some other reason?
Seizures can be due to seizures.
Could have been seizure. So you should take more of the history. How did the child fall? Was it forward, backward? Did she lose consciousness after the fall? All this you should have brought out. Otherwise, how do we
Okay.
know how she fell down? Whether she had
Okay.
tripped and fallen. Because of when a child is spastic, no, the child would trip and fall. Then
Okay.
ataxia causing falls is different. And so also seizures causing falls, you could get loss of consciousness associated. There's no history of any major trauma due to the falls. Um, if he had a seizure and fell, so we would have expected the child to have had a minor trauma at least. He was not going for playing in the school ground and not participating in running games. Now, okay, that shows that you will, that's all. And he started schooling at 5 years and below average scholastic performance according to mother and teachers. He had difficulty in memorizing poems and stories and difficulties in writing. What exactly was the difficulty in writing? I think you have said that he can write his name, but they form bigger letters and letters are scattered in the page. What does it tell you?
It may be due to a tremor of hands. He may be
Anything
having
else?
difficulty writing letters.
No, you have said that very clearly. And what does that last sentence tell you? It tells you very clearly about something. What is that? They are bigger letters. Bigger letters are seen in cerebellar involvement. And where do you find smaller letters? Where do you find small letters? When there is extracerebral tract involved, the letters become small. And so
Okay.
this is an evidence of cerebellar involvement. And the letters are scattered in the page. So the next slide. The next slide. He was able to eat food by himself, but there's a history of spilling of water from a fully filled glass when he tried to have it. So that again is what does it tell you?
Due to incoordination and tremor.
Okay, then the next statement. Okay, the next statement.
He had tremor of fingers when trying to bring food and water to his mouth, and while holding pen.
What does it tell you? Someone has
Okay.
answered that he has intention tremor. And while holding pen means he had, in addition, he had some action tremor also. That is, intention tremor is brought out when you try to reach a target. And when the tremor was there, when you hold the pen, it shows that he had an action tremor. He had no history of difficulty climbing upstairs. So what does it tell you?
History of proximal muscle weakness.
Weakness. So immediately you should have told us whether he is having weakness at the knee joint and at the ankle joint. See, because you told us that there is no proximal muscle weakness. We would like to know whether there is middle or distal weakness. Somewhere else you said that there is no difficulty lifting of the arms, which again told about proximal weakness. But again, you said that he could eat food by himself. Maybe you meant to say that the elbow, the power around the elbow joint is normal. And then we would like to know whether he had any difficulty gripping, whether he had any difficulty making a bolus food. All this would have told us that the distal muscles of the upper limb are normal. And you should have said that during the falls, whether he buckled at the knees or whether he tripped at the foot, said we would know whether he had middle and distal weakness. So he was taken to the pediatrician at 6 years and advised to start the speech therapy. No detailed evaluation was done. That statement is superfluous. Speech therapy was taken only for 1 year and then stopped on their own as they did not notice any improvement. Again, superfluous statement. Next slide. Due to persistence in symptoms, child was taken to another hospital at 7 to 8 years and advised for IQ testing but was not performed. Okay, all that should not be presented in a case presentation. No, but the doctor said something it was not done. As time progressed, the symptoms remained same and the mother did not notice any worsening. So, which of the symptoms remained static like that? In the beginning, you said that there was progressive unsteadiness. That's what I remember.
As
Did
age,
you say
he has
that?
no increased frequency of falls was noticed by
How
mother.
long did the symptoms progress then? There was some progression in the beginning, no? How long did it progress? When did it plateau off?
It from about 6 years till his presentation, his symptoms almost was
Remained the same.
remained the same.
What about which symptom? Was it the unsteadiness or the scholastic performance that remained the same?
Both.
Both remained the same. He was not able to do simple math calculations like addition and subtraction, and there was reduction in intellectual function as compared to peer children. At
now
13
also,
years, now also?
Now also his intellectual abilities like that. Now also he's not able to do calculations, and now he can only
Can
write.
he recognize colors?
Yes, ma'am.
He can. Did you really ask him? He can recognize colors.
Yes.
He can. Can he count?
No. After 10, he can't count.
Pardon?
Only up to 10, mother told her.
By counting, we refer to him bringing 3 objects when he's asked to bring 3 objects, or 5 objects when he's asked to bring 5 objects. Saying up to 10 is recitation, not counting. Counting things, no? So you should find out whether the child can count and bring objects, not reciting up to 100, no? So at 13 years, he had an OPD visit for fever and rhinitis. It was advised to the pediatrician to consult the pediatric neurologist for detailed evaluation. Okay. So he was incidentally seen at the hospital.
Yes,
so the next slide. Next slide. So you have said a lot of negative points. Which is the first slide showing the negative points? This is the first slide. He had no history of difficulty in perception of smell. Okay. Why did you say all this? You can say that there are no symptoms related to the cranial nerve function. It's okay. You can say this way also. No problem. So, why did you expect him to have a defective smell?
In case of intracranial tumors.
Okay, right. But he's having ataxia as a major symptom, and that is in the posterior fossa. You don't expect smell to go. Okay, go on. Next slide. So what was your presumed diagnosis in the history of present illness which prompted you to ask for all these negative symptoms? What is the summary and the localization from the history of present illness? The summary of your findings.
Summary. A 13-year-old male child who is third born child to non-consanguineously married couple with uneventful antenatal and birth history, with no developmental delay and no relevant family history, with history of a simple febrile seizure.
Which child has developmental delay from at least 1 year of age? Because the child started walking only by 1.5 years. Now, no developmental delay until then. You did not bring out that in the history, no? That the child is developmentally normal until 1 year. He was obviously developmentally normal up to 1 year. Okay.
And his history of simple febrile seizure at 1.5 years, brought with complaints of slurred speech noted from 3 years, unsteadiness while walking with wide-based gait, and occasional falls from 3.5 to 4 years, and cognitive impairment. It's brought for further evaluation and management.
And added, you have written the family history also. There is no family history, relevant family history. So from this, what is the anatomical localization of your illness? Actually, you did not tell us about the pyramidal and the extrapyramidal system. We presume that's all normally from history. And so what is the anatomical localization?
Cerebellum involvement.
It could be cerebellar involvement. Could it be anything else?
It can be vestibular.
But you said that when a glass of water is being taken to the mouth, there was a tremor which is causing spilling of water. At that point of time, I would have liked to know whether it is the same with both the left upper limb and the right upper limb. You understand? Because it could be because you had in your mind a cerebellar tumor. It could be on one side. In that case, it could have been on one side. So we would like to know whether this spilling of water occurred while drinking with the right hand and with the left hand. Okay. So it could be, it is one of your localization is the cerebellum.
Okay.
Okay. Any other localization? Any other localization?
Can be due to gray matter diseases can also
Produce intention tremor. You have brought out intention tremor very well in your history and also an action tremor, I think. And a cerebellar involvement. How can that occur in a gray matter disease?
okay.
By gray matter disease, what do you mean?
Matter disease.
What do you mean by gray matter disease? Can you name one gray matter disease? One gray matter disease. What do you mean by gray matter disease? When we speak about gray matter disease and white matter disease, we normally refer to the lysosomal storage disorders. It's a way of classifying them depending upon which part of the nervous system is first involved. Like, for instance, when you have GM1 gangliosidosis or GM2 gangliosidosis or Gaucher disease, the gray matter is first involved. So you call them gray matter diseases. And when metachromatic leukodystrophy, dystrophy, TRAB, and all the white matter is involved, then you call it white matter disease. So in this patient, you don't think about the lysosomal storage disease of that manner because usually lysosomal storage disease is producing gray matter involvement. Usually there is an onset before 1 year of age. Of course, there are exceptions where it occurs later. And gray matter disease usually associated with hepatosplenomegaly. They have a obviously protuberant abdomen.
Okay.
And seizures are a part of the history. Usually, that is a usual thing that makes us think of a gray matter disease. If at all, when a patient presents a progressive cerebellar involvement, you think about a white matter disease. And at this age, you don't think about a white matter disease that way. What are the cerebellar involvements? We were talking about the anatomy. The other anatomical localization is the brainstem, where the cerebellar connections go through. No? It can be the cerebellum or the brainstem can be the anatomical localization. And what do you think is the etiology at this point of time? One you have already said it could be Wilson's disease. Wilson's disease, one of the causes of scholastic underperformance and cerebellar involvement with tremors. You also brought out the action tremor. And what are the other diseases that affect the cerebellar system at least? Cerebellum and its connections at this age. There are both autosomal recessive diseases and autosomal dominant diseases. The child is born to non-consanguineous parents, so you cannot straightaway think about the autosomal recessive diseases. Still, what are the autosomal recessive conditions that produce cerebral ataxia in a child?
Friedreich's attacks.
Friedreich's ataxia. So, thinking about that, we should have brought out in the history, while saying the history, you could have said that the mother has not noticed any deformity of the foot because you get clubfoot in Friedreich's ataxia. So, what are the other recessive diseases? I think you did say about deafness and all. So, Refson's disease, then A-beta, you did allude to that in your negative history. I heard that. You said there is no diarrhea and all that. A-beta, then
ataxia telangiectasis.
Ataxia telangiectasis. So even in the history, you can say the mother has not noticed any lesion of blood vessels anywhere in the body. especially on the
Oh,
conjunctiva. Now, what are the
oh,
typical autosomal dominant diseases that produce chronic ataxia? The spinocerebellar ataxias. There are a group of diseases called spinocerebellar ataxias. So, since there is no consanguinity, you can seriously think about spinocerebellar ataxia also as an etiology. So, why should we dissect out the history in this manner? Today, it's very easy. You can send for a clinical exam and find out the diagnosis. Why should we waste time finding out what disease the child is having clinically? What is the point? Mm.
for
Yes. Why not straight away go for the clinical exam?
clinical diagnosis and proper localization.
Why? There's no need. We can send the clinical exam, get the diagnosis.
We need to
Ah,
provide a detailed history.
when you ask for the clinical exam, is that the answer? When you give the request for the clinical exam, you should give the proper history. Is that the answer? There is nobody else to help her. That's the problem. People are writing in the chat box. It is not to avoid unnecessary investigation, as somebody has written. See, you have a differential diagnosis that we have said now. If you think about spinocerebellar ataxia, seriously, you need another test to test for spinocerebellar ataxia. That is why if you send a clinical exam, you are going to miss spinocerebellar ataxia. That in that way, that is the reason. Frederick's ataxia, you have to send for triplet repeat. You have to do a special test to look for triplet repeats. No? Triplet repeat primed PCR has to be done to look for Frederick's ataxia. So if you test for SA, you will not find out Frederick's ataxia. So you need a clinical diagnosis. You can't send for all of these tests together because it's going to cost around 50,000 rupees in that case. You have to clinically come to a diagnosis. So
Okay.
anybody else has to say something before we go on to the examination? Dr. Darshan? Has he left the place? Has Dr. Darshan left? Okay, shall we go on to the examination?
Okay, ma'am.
Hmm.
General examination. Child is comfortable, cooperative, he is conscious, oriented to time, place, and person. There is no pallor, no icterus, no cyanosis or clubbing, no lymph node enlargement, no edema. Head to toe examination. Head appears normal, hair
Just a
normal.
second, Dr. Gopika. I think this is unfair. You have to tell the vitals before all this, no? Patient may be in shock, patient may even be not alive. The vitals, no? General examination after the initial comment, you say the vitals, no?
Okay, ma'am.
The pulse rate, blood pressure. Before that, you do not look at the. That's what you normally do with the casualty, no? You look at the
Okay.
vitals.
Okay, ma'am. Vitals pulse rate is 98 per minute. It's a regular rhythm, normal volume character. There's no radial or radiofemoral delay, and all peripheral pulses are bilaterally palpable. Blood pressure is 190 over 86 mmHg, right arm sitting position. Respiratory rate is 26 per minute, regular and abdominal thoracic. Temperature is 98.7 degree Fahrenheit. Saturation is 99% under room air. A general examination, it's normal. Then head to toe examination, head and hair is normal. Mild nodding, head movements present. Tremor is present. Eyes, no nystagmus, squint or cataract. Iris and conjunctiva are normal. No KF ring or telangiectasia. No dysmorphic facies. Oral cavity, tongue, teeth, and tonsils visualized normally. Ear is normal, no discharge. no knuckle hyperpigmentation, no neurocutaneous markers, no skeletal abnormalities, external genitalia is normal. Coming to anthropometry, his weight is
Dr.
40.
Gopika, the previous slide. How do you look for cave ring?
I look with torchlight. We also
From this,
slit lamp examination. Also, we have to.
so from when you look for cave ring, from which part of the patient do you look for cave ring? The cave ring may be very elusive. You normally look from above the patient. You keep the child on a stool and you stare at the back of the patient, tilt the head backward and look for cave ring after shining a torchlight. So why did you look for knuckle hyperpigmentation?
So look for any B12 deficiency in B12 deficiency.
So you had mild nodding head movements present. Was it to and fro movement or side to side movement?
It was to and from up and down, like nodding.
Anteroposterior or side to side?
And
you don't have the video, no? Anteroposterior. Most probably. Okay. Because in cerebellar, you always get a yes movement, no? Okay. Go on.
Anthropometry, weight is 44.7 kg, 50th centile. Height is 142 centimeter between 3rd and 10th centile. BMI is 22.2 kilogram per meter square. Coming to central nervous system examination, higher mental function. He is conscious. He is oriented to time, place, and person. Right-handed. Speech is a slow scanning speech with unintentional pauses. He is able to comprehend spoken words. Repetition is good and fluency is affected and dysarthria is present. Cranial nerve examination. Olfactory nerve normal. Visual acuity is 6/6. Field of vision is normal. Color vision is normal. Fundus normal. Then oculomotor, trochlear, and abducens nerve. The extraocular movements are normal in all directions. Pupillary reflex, both direct and indirect reflexes are present. Accommodation reflex is present. A trigeminal nerve is normal. That is normal sensations over face. Clenching of teeth is normal. Corneal conjunctival reflex is present. Georgia could not be elicited. Then facial nerve is intact. That is facial symmetry present. Nasolabial folds are normal and normal forehead wrinkling, tight eye closure and blowing. And vestibulocochlear nerve, normal Rene and Weber test and no nystagmus. Glossopharyngeal and vagus nerve, gag reflex is present. Palatal movements are bilaterally present normally. No polygon secretions. Uvula is present in midline. Then 11th nerve, shrugging of shoulders are normal. And 12th nerve, bulk of tongue muscle and power normal, and there's no deviation of tongue and no tongue fibrillations. Motor system, bulk is equal, no wasting is seen, equal on both right and left side. Tone is also normal on both upper and lower limb. Power is normal in all joints, that is shoulder, elbow, wrist, fingers, hip, and knee and ankle joint. 5/5 power is present. And superficial reflexes are normally present. It is corneal, conjunctival, abdominal, premasteric, plantar, flexor response is seen. Then deep tendon reflexes are normally present. Plantar flexor response is present. And cerebellar signs, titubation present, intentional tremor present, no nystagmus, dysdiadochokinesia present, finger nose test in coordination present, path pointing present, heel to knee test also in coordination present, tandem walking unable to do, Romberg's test is negative, and there is no pendular knee jerk.
Just a minute, but you don't call it intentional tremor, intention tremor, and dysdiadochokinesia is spelled wrong. How do you look for it? Dysdiadochokinesia?
The alternating movements of hand.
Okay. Anyway, it's present in this patient. How do you look for pendular nature? How do you look for pendular nature?
There will be more than 3 times to and fro movements.
If it amounts to 3, it's a pendular nature. More than 2 and 3/4 turns. Okay. So the next slide.
Gait is wide-based gait with foot abducted and increased intermalleolar distance. There is no limbing or short limb. Mild swaying to either side is present with unsteady turns. Sensory system is superficial touch is intact, deep pressure, vibration sense, position sense intact, tactile localization and stereognosis also intact. Also no extrapyramidal symptoms. No autonomic symptoms or no signs of peripheral neuropathy. And no meningeal signs. Skull and
What are the
spine
different ways you try to bring out extrapyramidal signs in this patient? To bring out the hidden extrapyramidal symptoms. Other than simply eyeballing the patient, what did you try any maneuvers? Anything that you did to find out extrapyramidal system involvement? You can ask the patient to abduct the limbs and bring it like this to look for tremor, especially this is seen in Wilson's disease. So also you can ask the patient to stretch his arms forward to look for tremor.
Okay.
In addition to you're looking for tone and all that, you can elicit all this. Go on.
Other system examination. Cardiovascular system, first and second heart sounds heard normally, no added sounds or murmurs. Gastrointestinal system, abdomen is soft, non-distended, non-tense and non-tender. No organomegaly, bowel sounds are present. Respiratory system, chest is clear, normal vesicular breath sounds, air entry is bilaterally equal.
So you do not bring a video of the child, it's unfair, no? The video of the child is not available now. Okay. You go on.
Coming to summary of case. 13-year-old male child, third born to non-consanguineously married couple with no relevant antenatal birth or family history, with insidious onset of slowly progressive neurological disorder in form of ataxia, slurred speech and cognitive impairment, noted from 3 years of age. Examination shows positive cerebellar signs with no cranial nerve, sensory or motor system involvement. And the clinical diagnosis, 13-year-old boy, chronic ataxia, slurred and scanning speech, and with cognitive impairment, most likely due to involvement of cerebellum and gray matter.
Cerebellum and gray matter. What do you mean by gray matter? What do you mean by gray matter? You are referring to the cerebral gray matter.
Cerebral.
Right.
Cerebral gray. Yes,
you mean that you think of a disease that it's involving both the cerebellum and the brain and the cerebral hemispheres.
Yes.
The brain and the cerebellum, both the cerebellum. Okay. So what is your anatomical diagnosis not confined to the cerebellum? You're right, because the patient is having a cognitive decline also. Can you get a cognitive involvement in patients with cerebellar disease alone? You can. Cerebellar disease alone, you can get cognitive involvement. But this is good. It is a good localization because there is a scholastic involvement. You could postulate that there is a brain involvement and a cerebellar. So what are the etiological diagnoses that you can exclude with your this anatomical localization? You have localized the cerebellum and the cerebrum and a global cerebral involvement, right?
Okay, ma'am.
Right. So what diagnosis can we exclude now
We
by
can
making this anatomical localization?
Ataxic cerebral palsy can be excluded.
No. What is the first thing that you can rule out? You can rule out a cerebellar tumor, no?
Okay.
Because
Okay.
you are saying the cerebrum is also involved. What is the mechanism by which a cerebellar tumor can produce, can affect the cerebral gray matter, a cerebellar tumor, affecting the cerebral gray matter? What is the mechanism? If the patient has a cerebellar tumor that is obstructing the ventricular system and there is a secondary hydrocephalus, the cerebrum can also be involved. There can be cognitive decline. Isn't that so? So that is one mechanism, but directly, when you think directly, you can rule out a cerebellar tumor because the brain is also involved. So what are your differential diagnosis regarding the etiology?
Is most likely to involvement of cerebellum and cerebellar gray matter. So
that you already said. What is the etiological possibility?
It can be some neurometabolic diseases or neurodegenerative diseases.
Okay.
Diseases like mitochondrial disorders, metachromatic leukodystrophy, glutaric aciduria, Wilson's disease, some disease, then A beta lipoproteinemia and vitamin E deficiency.
In which among these do you get this titubation as a major feature? Because you have brought out titubation in this patient. You must have seen Lay's disease, metachromatic leukodystrophy and all. No? Among these, not all have titubation.
Okay.
Classically, it is ataxia vitamin E deficiency that presents with titubation. So also in type 2 glutaric aciduria, you can get titubation. That would probably help. Not that none of the others have, but these are the classic diseases to have titubation. So you have also postulated that the patient could be having ataxia telangiectasia. Could you have ataxia telangiectasia without telangiectasia? So this patient does not have telangiectasia. You can have ataxia telangiectasia without telangiectasia. Some of them, in very rare cases, you may not find the telangiectasia.
Okay.
So, Pelizaeus-Merzbacher disease. What are your points for and against it? Pelizaeus-Merzbacher disease. You have written it as the last possibility.
It will be usually the regression symptoms.
I cannot understand. Pelizaeus-Merzbacher disease, you don't get a dysmyelination, you get an amyelination. The myelin does not form at all. So the Pelizaeus-Merzbacher disease normally presents in the newborn period because there is amyelination. The phospholipoprotein is not formed at all. And they have a very classical clinical feature, which is what is the classical clinical feature of Pelizaeus-Merzbacher disease? You have a pendular nystagmus because there is severe optic atrophy. So also they are spastic and not, it's not cerebellar ataxia which is standing forth. Possibly that's the reason you have given it the end of the list. Okay. But I would bring spinocerebellar ataxia further up in the list of diseases because this patient is having pure cerebellar ataxia according to you. I'm not examining the patient and therefore I do not know. And glutaric aciduria usually presents with extrapyramidal symptoms. Though cerebellar ataxia is a part of the scenario, extrapyramidal will be prominent. Though Wilson's disease usually presents with extrapyramidal symptoms, it can present with ataxia alone. You can have a progressive myoclonic ataxia, where there is progressive ataxia with myoclonic germs. Again, Refson's disease, you have deafness, you have peripheral neuropathy and all. A beta lipoproteinemia could present with cerebellar ataxia alone. That's a good DD. So these are the differential diagnoses, but I would like to bring Ataxia with vitamin E deficiency and glutaric aciduria are further higher in the list with the spinocerebellar ataxia also. Anybody has any other opinion? And the fact that you said that it is static for some time, no? That's very clear that it is not progressing, that it is not steadily progressing. So you should also think about the remitting ataxias also, those that do not relentlessly progress. Should think about the ataxias that come and go. And can you name some of them? Episodic ataxias. The intermittent or the remitting ataxias, which are the inborn errors in metabolism that produce remitting ataxias or episodic ataxias. This is mitochondrial cytopathy, Lesch-Nyhan syndrome, urea cycle disorders, MSUD, right? Someone has said it's MSUD. So you could think about them also, because this child has been static for some time.
Okay.
So anybody has any opinion about the etiology in this patient? So shall we go on to the investigation findings?
Okay. We have done a complete blood count, renal function test, and serum electrolytes. All were normal. Also, we have done thyroid function test for this child. After that, we went for imaging. This is the MRI findings, which showed a bilateral symmetric T2 flare hyperintendent signals in cerebral white matter with subcortical predominance, basal ganglia, internal capsule, and dentate nuclei, with restricted diffusion in posterior limbs of bilateral internal capsule. This is the
Okay. So from the clinical features, like I said, the titubation was very odd. You don't find titubation normally in our children with ataxia. It is ataxia with vitamin E deficiency and L2-hydroxyglutaric aciduria presence with titubation. So what is mentioned in the literature and what we rarely see in our practice is true. So that is why actually I have not seen a case of ataxia with vitamin E deficiency, only read from the books again and again that it produces titubation. So L2-hydroxyglutaric acid I have seen with titubation. So this has now strengthened the idea that L2-hydroxyglutaric aciduria you get titubation. I think titubation is a rare finding, and so it should have made us think about L2-hydroxyglutaric aciduria. So how do you confirm the diagnosis of this patient? Okay.
and urine and clinical exome also.
Okay. So what they show the urine GCMS that you've done? What do you find in that?
We have detected elevated level of 2-hydroxyglutaric acid.
Okay. Elevated level of 2-hydroxyglutaric acid, you saw that. And the clinical exome gave you your diagnosis. See, if we had stuck on to the diagnosis of spinocerebellar ataxia, we would have sent the panel first. I don't know whether you sent the panel first.
No, ma'am. After MRI, we send.
Yeah. MRI was very suggestive. Okay. So also there are people who send the clinical exome before the MRI. That is also there. No? So you should wait for the basic investigations to come. Only then send the genetic investigation, because you will get an idea from the basic investigation what genetic investigation we have to send. Otherwise, with child with pure ataxia, one would be tempted to send the SCA panel, and the patient will lose around 12,000 rupees for nothing. So that waiting for the MRI did help with this patient. And next time also from the clinical history, you will think about ataxia with vitamin E deficiency and L2-hydroxyglutaric in a patient presents with titubation, right? So
Yes.
they are, it's autosomal recessive and homozygous. And it is classified as pathogenic. This mutation is classified as pathogenic. Now, how will you give genetic counseling for this patient if this is the first child?
This is autosomal recessive, 25% chance of recurrence.
What will you look for the parental? Will you do the parental testing?
Yes. Yes.
And what will you conclude from that? If the parents, both the parents do not carry the gene, it could be a mutation in the germ cell, no? And
Okay.
therefore, in this case, the next child may not have a chance of having this. If the parents both the parents are carriers for this gene, there is a chance of 25% chance of recycling, and you have to do a parental counseling for termination of the next child is having the same. Okay, so how, is there any means by which you can treat this patient? You must have looked up, no? Did you look up?
We have started on riboflavin and carnitine.
Okay. But the recent reports are saying that riboflavin is not as useful as we thought in the beginning. As I mean, people who worked on it thought in the beginning. Anyway, we are also giving riboflavin whenever we think the patient is having glutaric acid. That's right. Okay. But the literature is now speaking that riboflavin may not be so useful. So, how much of riboflavin are you giving? How much of riboflavin are you giving the patient?
100 mg.
What is the strength of a tablet of riboflavin? One tablet of riboflavin is how many milligrams? It is a 10 milligram tablet, and the dose usually comes to 200 milligrams. You have to take 10 tablets in the morning and 10 tablets at night. Okay.
Okay.
Anybody has any doubts? Gopika, what's the dose of carnitine?
Carnitine?
Dose.
We are giving 500 mg tablet. BD, 500 mg BD.
We have pediatricians, no? So, what's the milligram per kilogram dose? Milligram per kilogram dose of carnitine, 50 to 100 milligram per kilogram per day.
Okay.
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 So, any doubts? Everybody has understood everything.
Any PGs having any doubts, kindly please ask. Any contributions, any comments, any doubts? I think
That
either
was
they
a
are
very, very
sleeping.
good case.
Yeah, it was a very good case. Yes, madam. Any questions? Okay. So, madam, shall we wind up then, madam?
Okay.
Okay, madam.
One thing you have to remember, I am Parvati. One thing you have to remember is...
Yes, madam. Please tell me.
It was a very nice case and discussion also was quite good. And one thing I would like to say is, even if it is autosomal recessive, even if you say 25% chance, each child can have it. Even if it is 25%, there is nothing that like 1/4 of the children will be affected. I had one of my relatives' children having maple syrup disease. All the children, 4 of them had maple syrup disease. It was very tragic. And at that time, there was no treatment as such for such patients in our place, years back. Thank you.
Thank you so much, Parvati madam.
Thank you.
Any other contributions from anybody? Okay. So thank you, Gopika, for that nice and wonderful case. And thank you to the mentor, Dr. Shaksya madam. And a special thanks to Dr. Mary madam, who is known for her clinical and academic acumen. Thank you so much for telling us all those teaching points. I'm sure the postgraduates would have really benefited from this particular discussion. Thank you all, and thank you for this participation of all the other members from different parts. Thank you all so much, and hope to see you in the next academic session. Thank you, madam. Thank you so much.
Thank you for the opportunity.
Yeah, thank you,
Thank you
madam.
so
The pleasure
much.
is always ours, madam. Thank you so much.
Okay, good night.
Thank you, madam. Yeah. Good night.